Hello, everyone. My name is Jen Braun, and I direct the AHA Team Training Program. Welcome to our second to the last webinar of the year, the Shame Competent Organization, led by Dr. Will Bynum from Duke University School of Medicine. And so this is a bit of a part two from his webinar he did in April about shame and sentinel emotional events in healthcare. So thank you for joining us. If you didn't join us back in April, we'll share that link to the recording in case you're interested. But before I hand it off to Will here today, I'm going to go over a few rules of engagement. So you can access audio by listening in through your computer speakers or through your phone. If you're having any issues, you should be able to access the toolbar at the bottom of your screen to switch to either phone audio or computer audio. And so please know that you're in a listen only mode, and all hyperlinks that you'll see on the slides here today are active. So keep that in mind. And then finally, I'll moderate a Q&A session at the end with our speakers. So if you have any questions, please chat them in throughout the presentation. If it's technical or logistical, we'll answer it in the moment. But if it's for our speaker, we'll save it for the end. We're happy to offer free CEs for our webinar. So to claim your CE credit, you must create a Duke OneLink account. Duke is our continuing education provider. And so this is a one-time only setup. So if you've never done it before, you'll have to do a setup, and my colleague Kara will be chatting in those instructions. And so you can also refer to the email that was sent to you this morning with the attachment as well. Following the webinar today, please text JOVTAG to the number you see there in order to claim your credit. We'll chat this in a few times and we'll share it at the end as well. Our offerings for the year are winding down. We do have 2 more in-person master training courses left with a few seats available. And we'll be announcing our 2024 course schedule soon, and we'll open up registration in the next month or 2. So keep an eye out for that. Next week, we're excited to have a bonus webinar on Wednesday, November 15th, sponsored by Relias on strategic onboarding to maximize employee retention. So registration is open, so feel free to register for that if you're interested. If you're looking for a more customized training solution, I do want to call out that we offer on-site trainings where we come to your organization to deliver anything from a 2-day master training course to a more comprehensive training program that spans, several on-site trainings and virtual coaching to really help support the spread and sustainability of your implementation efforts at your organization. So this also allows us to customize the content to your audience and really meet you, where you're at. So you can visit our website to learn more, and you can complete a brief questionnaire where one of our team members can reach out to you and schedule a one-on-one to chat with you in a bit more detail about those options. So that's enough of me today. I really want to get to our speaker. I'm so excited to have Dr. Will Bynum back, who's from, like I said, the Duke University School of Medicine. So Will, I'll turn it over to you.
Great, thank you, Jen. Kara as well for all the help with getting this, making this happen, for the invitation to return, and most importantly to everyone on the call, just for the chance to share some new work with you all around the broader topic of shame, which I've been working with for over 10 years now. And for also the chance to speak to such a diverse group of healthcare professionals. It's really fun going through the registration list and seeing not only just the geographic diversity represented, but also in terms of positions, job titles, et cetera. It's just not a group that I get to spend as much time as I would like with. And then also a sincere thanks for all that you do in healthcare. It's obviously just such a team sport, and you probably don't get the thanks you deserve on a daily basis. So thank you for that. So this is a follow-on talk from one that I did about 6 months ago. I don't have any financial disclosures related to this talk. Occasionally I do get paid to give these talks. I'm not getting paid for this one. That would be the only disclosure related to this work that is probably pertinent. But this is certainly not a financially incentivized passion for me. And I think you'll understand a little bit more why as we go through. So 6 months ago, I had the really amazing opportunity to speak to this group for the first time. And I focused that talk on really a topic and an overview, or an overview of the topic that I frequently give. And if you don't need to have seen that talk to derive benefit from today's, but it may dovetail nicely if you do have the chance to go back and watch it. I presented a bit more of a personal sort of journey with the emotion of shame, and then a kind of a wide-ranging overview of the research we've done and how this influences medical learners and can be extrapolated more broadly to healthcare. And in that talk, I kind of shaped the topic around the metaphor of fire, and it being an emotional experience, shame, that can really catalyze a major reaction in an individual with lasting effects. Some positive, some negative, but can really be what we call a sentinel emotional event in our research. And as a part of that talk, I almost regret not being able to do this again today, because it's really one of my favorite things to do when I speak on this topic is to share some art and graphic medicine that we have partnered with professionals to develop. And we went through this series of panels kind of dissecting what can happen in a shame reaction and drawing attention to some of its more salient features and its more recognizable features, as well as those that are not so easily recognized. If you're interested in, bypassing watching the talk, but just want to spend more time with the art, I've put a link to our website down here. Everything is open access and free. And this series of illustrations, as well as 5 others, are included on that site, which provide really meaningful ways to sort of engage with this topic. A lot has sort of catalyzing for this work in the 6 months since, and this really is an opportune time to try and take this topic to another level with you all, and in many ways to try out some ideas that are really in their nascency that we're developing. And the development of this work has been really moved forward through the founding of an entity called the Shame Lab with my good friend and colleague Luna Dolezal from the UK. And so Luna is a shame researcher. She's an academic philosopher, a brilliant mind, and one of the other sort of people examining deeply shame in healthcare. And so we naturally found ourselves through some joint projects, and now have really partnered for what is likely to be a career's worth of work. And so the framework I'm going to talk about today of shame competence comes from this partnership. And actually the term was originally coined by Luna and is now serving as the backdrop of our work. The reason that this framework has come to sort of come into our awareness and is that it meets a need for us as researchers and as just practical people living and working in academia and in healthcare to actually do something with all the information that we and others are learning about what it means to experience shame in healthcare. So this is going to be a more practically oriented framework that is built upon some key features of shame that I'm going to articulate for you. And when I did my PhD at Maastricht University, which is in the Netherlands, it's a European style PhD. One of the neat parts of the dissertation at the end was that I had to propose what are called propositions, and they exist on a bookmark inside my dissertation now. And the propositions were the 10 kind of key arguments that I wanted to make after these 3 or 4 years of research in this huge dissertation. And the thing I loved about it is that it distilled down the real impact and the meaning of what all the research was oriented towards. And it really forced me to think more globally about it. It also forced me to think logically about the things that we were professing out of this research. And so I'm actually going to use that format to frame this talk. So I'm going to give you 5 propositions now that really I need you to at least to some degree believe in by the end of this talk in order to be willing to put some of this into action. And that more importantly, I hope to convince you of as reasonable, if not holding some degree of truth for you. So the first proposition I'm going to put forward is that how we feel about ourselves as we serve others in healthcare, and this is absolutely a service-oriented field. It is for other people, but there is a key component of this experience that revolves around how we feel about ourselves. It has profound impacts on the nature of that service that we provide and our experience in providing it. So I'm going to center self-evaluation, how we feel about ourselves in this talk. We are in the realm of the self-conscious emotions like shame and guilt and pride and embarrassment, which arise when we consider how an event, a series of events, or circumstances make us feel about ourselves. The second proposition is that, and if you practice in healthcare long enough, this is going to have a lot of face validity or face value to it. In healthcare, failing to achieve our ideals and our standards is inevitable. And this is kind of a uncomfortable reality I think we need to sit with. But if we deny this, we're denying the true nature of the imperfect nature of healthcare and humans that practice it. Our standards in general and our ideals center around helping people navigate towards better health, helping to alleviate suffering, helping them to improve their quality of life and their well-being. And because medicine is such an imperfect practice, and because circumstances are so often out of our control, and because the nature of what we do is so difficult and challenging, and the systems are so flawed, frankly, is the reality is that we are going to fail to achieve those lofty standards we have for ourselves, for our institutions, for our systems. It's going to happen. Now, we do our very, very best to mitigate those failures and the impacts of those failures, but I'm hopefully going to convince you that failure is inevitable in what we do. And then if we agree to that proposition, then there's a proposition that follows that's really critical. And that is that shame often lies at the heart of our responses to those failures. And this is because the standards and ideals that shape the work we do, right, that set the marker of success, of achievement, of what is acceptable and good enough, are deeply linked to who we are as people, right? That is the nature of being in a profession, that our self-concepts, how we know ourselves and feel about ourselves, is intricately interwoven with the work we do. And that work is flawed, and that work will engender failure, and therefore it is very easy, and we are all at risk of perceiving failures of the self related to failures of the work. And that is what shame is. Shame is essentially an attribution to a globally flawed self. And so I'm going to define that for you in a minute. But if we agree that failure is inevitable, and shame is attached to failure in many ways, given the nature of what we do and the fact that we're human, then shame becomes potentially inevitable as well, or at least very likely. And then following from that is that shame itself is an emotion that can have profound, truly profound effects on well-being, on engagement, on team function, organizational culture, and ultimately on patients. We are all existing in these complex systems. We all have things at stake. As we do that, patients have the most at stake. And so shame, while it may initially or most abruptly affect us as individuals, as healthcare providers or professionals, it is not far downstream where the effects on patients will be felt. And that comes through numerous ways that shame manifests within an organization, many of which we're going to talk about. So if you agree with these four propositions, then you need to agree with the fifth one. And this is the one that matters. It's that if failure is inevitable, if failure can engender feelings of shame, and if shame can have these profoundly negative or even just mildly negative reactions or impacts at times, then we have to have healthy, constructive ways to engage with shame in healthcare. That's simple logic in my mind. And despite the fact that we can build an argument for that, and that it rings true for many of you, or at least valid, we don't have healthy, constructive ways to engage with this right now. And that's partly because we don't talk about this emotion. It's partly because we haven't developed the vocabulary, the frameworks, the training, the forums, the safety, all those things that are required to engage with something as challenging and personal and stigmatized as shame. But we can't accept that. If we accept that this is just an emotion that's going to happen that can have profound impacts, and we don't do anything about it, we are really, we're putting patients at risk, we're putting ourselves at risk, and we're setting the bar too low for the quality and nature of the work that we can do if we engage more constructively and proactively with it. So what I'm here to talk to you about is a framework about how we might begin engaging in that healthy, constructive interaction with shame and really in a transformative way. Okay, so with that backdrop, the objectives today, I would like for you to be able to describe or define shame, and then list a few different characteristics about what make it so unique and powerful. And I'm going to walk you through some of those core features. I want you to be able to just to explain what I mean by the distributed nature of shame across an organization. This has been really important in the way we are thinking about addressing shame within an organization, and understanding that it distributes across multiple dimensions. And I'll tell you more about that. I want you to be able to define shame competence. And I want you to be able to talk about and describe how shame competence can be transformational within an organization in all of its many components. And then, to the best of my ability in this very short amount of time with a complex topic, I do want to try to convey some foundational skills that you might begin to immediately apply in adopting a shame competent approach to your work. The fact is that to really become shame competent at even more than a very nascent level requires immersive training and immersive reflection and thinking and discussion, which we're developing. But even in 30 to 45 to 50 minutes of a talk, I do really want you to walk away with a few key strategies. Okay, so I'm going to just define shame for you here. And there's many ways this has been defined in psychology. The one that I've worked most closely with is from a leading theory that says that shame results from a self-evaluation in which we identify ourselves or see ourselves as falling short of our standards or ideals. So we view ourselves in a way that is discrepant or distant from the ideal self. And we attribute that distance, we attribute that discrepancy to something global about ourselves, something stable, not easily modifiable. So, for example, my intellect, my capability, my how I look, how I think. The story I told in the last webinar was about a terrible medical error that I made, my first bad one really in residency, and the crippling shame that I felt thereafter. And the way I felt about myself in the aftermath of that error was so globally negative that it was extremely painful, but it also really is a hallmark of a shame reaction. So I felt incompetent, untrustworthy, like I had fooled everyone at that point in my training, like I wasn't worthy of practicing medicine or being given responsibility, and that I just didn't belong. And so that sort of negative global assessment of the self is a hallmark of shame. Shame often includes feelings of being judged by others, and it can be actual other people or just imagined other people. So we see ourselves through others' eyes, real or imagined, and then there's an attachment of judgment and a negative judgment of the self with that. And this is contrast to the emotion of guilt, in which we fail to reach a standard. We see ourselves as distant from that standard, but we attribute it to something more specific, something more unstable or modifiable or actionable. So a guilt response to my error, which happened during a childbirth, would have been that I feel terrible about this. It's a negative emotion, but I need to learn how to do a vacuum assist delivery. I'd only done one before. I'd been up for 24 hours. The woman was having a placental abruption and the baby was dying. And I saved the baby's life, but I also caused a maternal injury. That I was early in my training, that I failed to speak up and say that I wasn't comfortable. All of those were attributions to the distance of my ideal and real selves, but didn't have anything to do with me in a global negative sense. And what we know, and I'm not going to go through the psychology of this for this talk, but please do refer to my other one where I do, is that guilt is generally a more constructive emotion, because when we feel guilt and we have something that we can attribute that distance to, the natural tendency is to go about fixing that deficiency. And it's much easier to fix, being willing to speak up or getting some sleep than it is being incompetent, right? And so guilt is a more constructive, growth-orienting emotion, whereas shame can be a much more profoundly negative emotional experience because it drives hiding and disengagement, and at times sort of reflexive anger or denial or shifting of blame. And I'll talk a little bit more about that nature of shame in a minute. So when we started developing this concept of shame competence, which I'm going to define for you in a few minutes, we collated work from psychology and from our own academic work, Luna and me, we collated a list of features of shame that underpin this practice of shame competence. And so these are the things that you really need to know about, or at least be aware about in order to develop shame competence. It also just gives us meaningful and useful information about the nature of shame and what makes it a unique emotion. So the first of the 8 or 9 features I'm going to give you is that shame is a normal and evolved emotion. And that is critically important to understand and to really accept, because it's an emotion that feels so bad and that we often want to deny or get rid of or not experience. But it's here with us in human existence at this current time for a reason. And it's because it has evolved. It has prosocial functions. It is a very powerful driver of our behaviors and our decision making. Okay, it's some psychologists have called it the master emotion, because some will say there's little we won't do to avoid or to get out of the feeling of shame. It really motivates us to make some adjustment to dissolve that feeling of global inadequacy or incompetence. And so it does motivate our behaviors in a prosocial sense sometimes. So you can imagine coming along in evolution, you were a group of roving cave people, and if you did something that really threatened the bonds of the group and were shunned from that group, right, and you were shamed and made to feel unworthy and like you didn't belong, you would be pretty motivated to quickly come back into alignment with that group, or you're going to be roving the tundra alone with, woolly mammoths and all the other things my kids are into these days. Probably not, I guess not dinosaurs, but big things that could eat you, right? And so there's a natural tendency to want to quickly come back into alignment with those group norms as a way of ultimately survival. That emotion has persisted, and in many ways it drives us to stay in alignment with those norms and standards. And so shame serves a very critical purpose in a functioning society. Therefore, please don't walk away from this talk thinking part of shame competence is just not feeling shame. That is a form of maybe psychopathy. We need to feel shame. We have to have a capacity for it. It's when shame goes off the rails where it becomes a problem. And so to that end, while it has prosocial functions and benefits, it can be easily pathologized, very easily pathologized. And so far as it can be emotionally destructive, it brings with it a lot of emotional distress, hiding, isolation, the need to protect a wounded self. It can therefore make us even more antisocial, particularly if we adopt a more sort of defensive or blaming posture in the feeling of our own shame, and that distances us further from groups. When we study this in medical learners, we see that it drives disengagement from learning. It reduces the tolerance for risk taking. It often puts us in places of extreme vulnerability where we can't continue exposing ourselves in that vulnerability, and so we just wall ourselves off. And in the practice of healthcare, you can imagine that has a lot of implications, right? On learning, on engaged patient care, on our own well-being, on things like willingness to report errors and so forth. So shame is not all bad, but it can become easily pathologized. And that's the type of shame that we're really wanting to engage with in a constructive manner. The fourth is that this is, like I've sort of alluded to, this is a self-concealing and invisibilized emotion. It's the term Luna uses that I like. It's an emotion that naturally does not want to reveal itself, right? If we may feel it and be aware of it. Often we're not even aware of our own shame. In fact, part of shame competence for me has been recognizing, oh my God, that's shame I'm feeling right now. No wonder this feels so terrible. But it's almost like my mind doesn't want to accept that I'm in a shame state because it's a painful place for me to be. It's not a place where I really like myself very much. And so it can be really hard to admit my own shame to myself, much less recognize it. And then certainly recognizing it in other people can be very challenging, because this is not something we walk around outwardly professing. It's stigmatized, it's painful. It comes with negative self-beliefs. And so along with that tendency to hide in the midst of a shame reaction is to hide the shame itself. And so what this means is that we are walking through the world and shame is probably all around us. And it's probably particularly surrounding us in environments where it's more likely to occur, i.e. in healthcare and high stakes environments where failure is inevitable. And so what you're going to see is that a key component of shame competence is the willingness and ability to be aware of the potential for shame. That's the foundation of shame competence. And that comes from the reality that shame is a self-concealing and invisible emotion much of the time. So we have to be extra aware of its possible presence. The sixth is that shame circulates interpersonally and across power gradients. There's a just wealth of psychology around this. And this is perhaps one of the ways we see shame most manifest, particularly in medical learning environments, is across what are steep power gradients. Healthcare is a highly hierarchical environment. It is hierarchical in some ways out of necessity. Someone has to be in control in the operation and has to direct other people, if you're in the operating room. Someone has to sign the orders and assume the liability at the end of the day. So there's necessary hierarchy, but we are also, some might say, pathologically hierarchical in ways in healthcare that really put patients at risk ultimately. And at an emotional level, the power gradients set the stage for emotions like shame or humiliation or bullying to occur, whether it's real or perceived. What we know is that shame tends to flow across those power gradients, and it can circulate interpersonally, and it can circulate very insidiously interpersonally. Even just disrespectful treatment or uncivil treatment can lead to crippling shame in the person receiving it. And then if that pervades an environment, shame becomes sort of entrenched, is a part of that culture. Similarly, because shame can flow across power gradients and power gradients often exacerbated, it is also used frequently and is a tool of conformity and control. And there's just, ledgers and ledgers and ledgers of history where shame has been used to coerce, to oppress, to control people, individuals. Because it has such a social function, and because it can drive a wedge between belonging so significantly, it can be used to sort of manipulate through that source of control. So you have to adhere to my standards to be in my group, right? Or to find belonging here, you have to meet those standards. And if you don't, well, I'm going to shame you, or you're going to feel shame, or we're going to make you feel shame, whether explicitly or not. And so that, of course, has the real impact of just driving significant injustice and inequity in our systems, in our society. Where you find social injustice and where you find racial or ethnic oppression, you're going to find shame. It's a very powerful tool that drive people to conform, often against their will, and can lead to significant assimilation trauma and assimilation pressure. And that tool exists significantly in healthcare. You could argue, it's maybe a bit of a controversial argument, that a lot of quote unquote professionalism, what is deemed professional, has shame baked into it, right? That you need to adopt a certain approach, a certain demeanor, a certain appearance to become professional or to be professional in healthcare. And if you don't, well, we're going to remediate you, or we're going to punish you, right? That would be an example of using shame, which is very likely to exist at that interface, as a tool to drive conformity to a set of standards. Now, the reason that's a controversial argument is that we need professionalism. We need professional standards. We can't just be running around standardless. But the ways in which we expect people to adhere to those, and the tools that we use, and the standards themselves need to be examined very carefully, particularly when we think about the emotional impacts like shame that may result from them. All right, the eighth is an extension of this, again, is that within an organization, shame can be embedded in, and I think actively mobilized by, that's the real need of this, by our policies and our practices and our pedagogies and the material conditions of our environments, in order to drive adherence to standards, in order to motivate behavior change, good or bad. That because it's an invisibilized emotion, we often don't even recognize that it's operating, and yet we have integrated it into our policies, into our practices, and into those material conditions in ways that can have pervasive and sustained effects at the level of the organization all the way down to the individual. And so we're going to talk about the component of shame competence that addresses the potential for shame to be embedded within an organization. And you don't have to look very far in healthcare to find some of that. Just a great example is the ways that state medical boards publicize, physicians or nurses or practitioners who have substance abuse issues, right? That it's essentially a public shaming, which is absolutely going to strike fear in the hearts of providers and maybe serve as a deterrent for that behavior. But you can imagine what it must be like for the individual going through the substance use disorder to then also have it be publicly exposed, right? And so that's a complex topic. The public has the right to know, but what is the emotional of that practice or policy, which is embedded within our institutional norms or practices? So these are the types of discussions that this lens of shame competence at the level of the organization will drive. And to that end, and this is really important, and this is why trying to give a talk on shame competence in 1 hour is challenging, is that this is not just an emotion experienced by an individual. It is uniquely individual in ways because only I could feel about myself the way I feel, right? You can influence that, but you can't make me feel any way about myself. Only I can feel that way. But it's not just about how I feel about myself. It's about the interactions with the people around me, right? It's about that interpersonal flow of shame. So there's a relational aspect to shame that is very powerful. There's an institutional aspect when we look at policies and practices, conditions that in which shame might be embedded and that might be operating. And then there's a societal level, right? Our society, one could argue, has deeply ingrained shame in many of its practices and policies. I mean, the criminal justice system is heavily shame inducing. It uses shame attached to punishment in many ways, or deterrence. And again, you could argue the merits are not of that, but the fact is that this is an emotion that is crossing many dimensions, both within our institutions, within our teams and ourselves, and with the broader society that comes into our hospitals, right? Into which we enter when we leave. Now, there's another, as we develop this concept of the distributed nature of shame and the movement that can happen among these dimensions, we had to also recognize a fifth dimension, which is the evolutionary dimension that I alluded to earlier. And the reason that this is a both important and also powerful dimension to consider is that in some ways it normalizes the experience of shame. All of these are ways that we feel, ways that we interact, ways that we build institutions and our policies, ways that we built society. But we haven't built our evolutionary growth. We haven't built what things have come along with it. That was the process of something much bigger than us, right? And so we're kind of stuck with shame. We can't get rid of it, and we can't evolve out of it, at least not in our lifetimes. And so we have to deal with it, one. And two, we all have this in common. We all have evolved as animals with this capacity for shame. And there's real power in that, in sort of developing shared experience and belonging and growth through attending to the fact that we are all stuck with this emotion together, right? And that can have transformative power when it comes to shame engagement. We'll talk about that. So that brings us to sort of the last point here, which is similar to the last one of my propositions, was that because of this complex, distributed, power wielding, sort of conforming nature of shame, and the nature of the work we do in healthcare and the likelihood that it exists and is embedded, we have to be able to acknowledge and address and constructively engage with it, not only to mitigate its destructive effects. That's sort of like level one, but level two would be to actually use it for good. I mean, shame is not an emotion that we should let go to waste. There is real prosocial benefit to shame, but how we engage with that experience is crucial in really influencing whether it's a more destructive experience or a more constructive prosocial experience. And for that, we have what we're calling shame competence. Okay, and so the ability to do this, to acknowledge, address, and constructively engage with shame, takes a lot of, I think, Luna and I believe, deliberate and intentional work. It's not that hard, frankly, because this is all just human stuff, but it does still need to be deliberate because of the nature of shame itself. And so I'm going to define shame competence for you, in order to now sort of pivot to the last portion of this talk about what we mean by shame competence and how we might implement it and then develop training around it. And I'm going to define it as we've defined it here. And that is, it's the ability to recognize, to acknowledge, to engage with, and to avoid inducing shame in order to leverage that prosocial potential and mitigate that destructive potential within individuals, teams, and an organization. Okay. What's really important, and we've struggled with this for a while, and I think really one of the reasons that I just latched onto this with Luna so hard, she came up with this term, was that I had been struggling a lot with the notion of shame resilience. And I had been thinking a lot about shame resilience, and there's a couple of theories that exist of it, and it's sometimes talked about in a way of achieving these outcomes of leveraging shame for prosocial good. But there's something, if you're in healthcare, if you're in any sort of on the ground conversations about well-being in healthcare right now, you know that resilience is kind of getting a bit of a bad rap. Not because it's a bad concept, but because the way it's being sort of implemented and talked about is a little bit problematic. It's as if it's a character trait that you should have or should be able to develop. And if you don't, then there's something wrong with you. And there's something you need to fix or you need to develop, rather than us creating a much more humane system, for example. So resilience wasn't working, and competence is it. Competence is the term, and it's the framework that I've been searching for. And the reason we like the notion of competence is that it suggests the acquisition of a set of skills and principles and practices. So this is not a character trait, right? This is something that can be learned, and these are specific skills that can be put into action to allow you to interact with your world, your environment, your people, your organization in a more constructive manner emotionally. So we can all become more competent with shame, and it has nothing to do with any other capacity we have for resilience or anything else related to it. Okay, so I really like the graphic here, because I have come to really view, and Luna has as well, shame competence is like putting on a set of goggles. It's like X-ray vision, and you just have this new way, or this expanded way of understanding people, interactions, team functions, organizational structures that you may not have had before without sort of the lens of shame attached to it. And so it provides this really powerful portal into these dynamics that otherwise we weren't previously seeing. So I love this sort of keyhole into this whole other universe, right? And that's really what shame competence provides, is it's a lens that we then make actionable. And so shame competence has 5 components. It involves maintaining awareness of shame, and I'm going to talk about each of these specifically. The ability to recognize shame, the ability to avoid inducing shame or to respond without causing shame, the ability to provide active support to someone experiencing shame, and then the ability to transform organizations and environments through this lens of shame that we apply to the work we do every day. So I'm going to the rest of this talk is taking you through these 5 elements, and I'm going to give you a few takeaways from each one and definitions, and then we'll finish with some questions. All right, so the first is maintaining awareness of shame. This is fundamental. This would be considered like level 0 of competence that you need to build to ascend to greater levels. And maybe if nothing else, today you walk away with some enhanced ability or really willingness to be aware of the possibility of shame around you. And so what this requires is that you, all the time, I mean, if you really want to do this wholeheartedly, you don't necessarily have to always be thinking about it, but it always has to be a possibility that someone else around you could be feeling shame, that potential exists in your interaction, in your environment, in your organization, and that shame is a likely emotion that could be going on right now. So if we're all sitting around eating donuts and having a good time on a Friday where we canceled clinic and everybody's just enjoying each other, that's probably not a real likely time that everybody's feeling shame. Now, if you're really shame aware, you might notice the person sitting on the side of the room outside of the group who's a little bit new or has never really quote unquote fit in with the group dynamic. who isn't engaging and who's just there out of sort of guilt, but actually could be feeling a lot of shame related to their perceived inability to fit in or belong, right? So even in situations where the likelihood of shame is low, the potential for shame still could exist. And so I think true shame competence is maintaining that radar all the time, but it's especially important in situations that are likely to induce shame, such as someone's going through remediation. There's been a medical error. You're having to counsel someone on a professionalism lapse, right? So on and so forth. We could populate a whole list of situations that could lead to feelings of shame. And in our research, we've done that. And it's still far from an exhaustive list. In those situations in particular, we need to maintain active awareness of the likely presence of shame. It's not inevitable. Many people could go through those situations and not feel shame, so we don't want to apply it to them sort of inappropriately, but the likelihood is there. Another way of maintaining awareness that I think is simple and actionable is to consider these questions. What is the likelihood that this event or situation has caused this person shame? Right? Just ask yourself that, or consider that. What's the likelihood that they are actually experiencing shame right now? And we're going to talk a little bit about how to recognize a potential shame reaction. You also might, in the course of developing relationships with people, know that they are more or less prone to these feelings. Some of the people in my life know that I am more prone to shame. And it actually helps me help them help me to tell them about how I'm prone to shame and why some of my behaviors might be driven by shame, and even I'm not aware of it, right? So some of this is helpful in just knowing people and their tendencies, but even when we don't know them, there are certain events that make shame much more likely to occur. This is the most practical, is to consider right now, how might this person be feeling about their self? And another way to do this is, how might I be feeling about myself if I were them? And if this sounds familiar to you, that's because that is essentially just enhanced empathy. Empathy is the willingness and ability to put myself in someone else's shoes and consider how they might be feeling. And empathy is foundational and critical in the practice of healthcare. All that I'm advocating for here is what I would call enhanced empathy. Don't just think about how they're feeling, but also go further and say, how might they be feeling about themselves? How might I be feeling if I just made this terrible error, or if I just got called out, or if I was just humiliated? How would I be feeling about myself right now? And what would I need from someone else? Right. So this is where shame awareness, I think, really comes to our sort of daily consciousness. All right. The second sort of pillar of shame competence is the ability to recognize shame. We need a whole multi-hour module to do this, because there's many different ways that shame manifests. There's many dimensions of that manifestation, whether it be cognitively, emotionally, through self-talk, through body language, interpersonal interaction, etc. I'm going to just give you and if you actually go back to my first talk in April, I gave a lot of sort of the phenomenology of shame, and the art really helps with that, to show you a little bit of how shame can manifest within a person. And I'm going to give you just a quick overview of what some of those are here. Pay attention to their self-talk, right? If they're saying things like, I'm the worst, I suck, I don't belong here, I feel like such a failure. I mean, those are global negative assessments of the self, versus if they're saying, yeah, I don't feel like I don't belong, but gosh, I feel so inadequate at, putting an IV in right now after, infiltrating their forearm and causing this huge, bout of pain. Yeah, a nurse that says, I'm never going to be good at IVs. I'm just not a good nurse. That's much more likely to be a shame feeling than to say, I just need a lot more practice with that IV, right? Which might suggest more of a guilt reaction. So paying attention to how people are talking about themselves, describing themselves, especially if you give them the opportunity to open up about that. And I'm going to talk about how to do that in a minute. Watch for the shame flush. This was described in our research as feeling like the color's draining out of my face, like I'm getting really red and hot, like my bowels just fell out on the floor, kind of the fight or flight response that can come with shame. So people that are just actively very uncomfortable and needing to sort of almost like physically disappear. That physical withdrawal can be a sign of shame, right? Someone that just is suddenly just not there. I mean, that's what I did after my error. I literally just handed everything off safely and left. and I don't know if anybody really noticed for a while, but that was very abnormal behavior to just leave in the middle of a procedure. Um, but it can be more insidious than this. Like, I'm withdrawing, and then I'm not asking as many questions, or I'm not speaking up as much. I'm not letting my personality shine, things like that. Physically, I might make myself small. If you're talking to me, I might be looking at the floor. I might be sort of almost like I'm trying to fold up into my chair. That can be a hallmark of a shame reaction. Also, more sort of exaggerated responses to shame, not so much the sort of shy vulnerability, but rather the more grandiose sort of anger, so disengaging, deflecting, projecting anger. This is sort of what's been described in particularly shame in men is the shame to violence conversion, where in order to deflect very painful shame, we use violence, or we use grandiose displays in order to sort of support a really damaged self, often at the extreme expense of others. There's some leading politicians that do this routinely now, and so you'll see this in the world around us. And a lot of times we react to the blame and the anger without recognizing that there's a really wounded person experiencing shame underneath it. And then also, sort of another compass of this, or part of the compass, is just being very insecure and needing a lot of validation, not being able to sort of survive or exist without constantly being reminded that I'm good enough, that I'm doing an okay job, right? And that's another sort of form of the self-centering nature of shame, which can be pretty frustrating if you're working with a person like this. But they're not necessarily going to tell you, I'm just feeling really down on myself. They're just going to constantly need that validation and to feel more secure. Okay, this is one of my favorite of the components to talk about, and I'm just going to briefly preview this in terms of what we've called the 4 types of shaming treatment. And so we've been working on better breaking down and differentiating what we mean when we talk about shaming treatment. So when you look at the dictionary, shaming is defined as just causing feelings of shame in someone else, whether you intended to or not. It's that they're experiencing shame as a result of your behavior. And so we've identified what we call the 4 types of shaming. And this comes from our work and is supported by the literature, but it's really out of our own brains here. The first is intentional shaming. When we intentionally shame someone, we are aware of what shame is. So I know a lot about what shame is now. So if I'm intentionally shaming you, I want you to feel shame. My intent is for you to feel shame, right? That is my goal. The likelihood of the behavior I'm manifesting towards you is high. That is going to cause shame. So if I'm screaming at you in public in front of all your peers and telling you how little you know and how stupid you are, that's very likely to cause you to feel shame. And that would comprise intentional shaming, right? And this is what we often see in abusive relationships, or in abusive teaching, or abusive care of other people. We also see it in public health campaigns, as a brief aside, where we are aware of shame. We want you to feel shame. Our intent is to make you feel it, and we're going to do it in ways that are likely to make you feel it. But that intent could actually be, while it might be sort of misinformed, it actually could be a good intent, where the means don't really justify the ends, but the ends in our minds are good. I want you to lose weight, so I'm going to shame you through fat shaming, for example, or shaming you because you smoke cigarettes because I want you to quit. The reality is, and the literature would suggest, that doesn't really work, and that's not a justified reason to intentionally shame people. But it's not just that intentional shaming is oriented towards making people feel like crap about themselves so you feel better about yourself. It's also at times even justified as treatment that is intended to help them, albeit not likely to do so. In inconspicuous shaming, we are not aware of shame. We're not sitting around thinking, I'm going to shame this person right now. I want them to just feel so bad about themselves. But our intent is still to make them feel a certain way about themselves. It's still to make them feel badly, right? And it's often done because we are discharging that on someone else. And the likelihood of them feeling badly in some way, or badly about themselves, is still there. So this is where I'm frustrated with you as a learner. You're not seeing eye to eye with me. I'm having a bad day, and I'm having a fight with my wife. And I often, inconspicuously or subconsciously, just need to make you feel bad about yourself, right? And this happens. This happens in healthcare. I mean, a lot, unfortunately. It's maybe not as totally bad as intentional shaming, because we're not just sitting around wanting to shame everyone, but it's not much better. And this, I'm going to argue in a minute, is unacceptable in our environments. The third type is mindless shaming, and this I think is rampant. And I think we have a different approach to mindless shaming than these other two. That's where we're not aware of shame. Yeah, no, I'm not very shame confident. And my intent really is not to make you feel like crap about yourself. Actually, my intent might be really good. I want you to learn something. But the behavior that I'm using is likely to make you feel shame. And in healthcare, we call this pimping. It's a terrible term, but it really means questioning you to the point of you not knowing the next question. And ultimately, the goal is, I might think, to teach you something, but in reality, it just humiliates you and can make you feel really bad about yourself. Or the way I talk to people in the operating room or on the wards or in the clinic, right? That the behaviors that I'm manifesting are causing you to feel shame. This is shaming treatment. I'm not doing it on purpose, and I'm doing it sort of in an aloof way, but it's still making you feel shame. And then finally, there's accidental shame. And this is where we are aware of shame. So you're shame confident, right? You're definitely not intending to make someone feel badly about themselves. And your behavior is executed in a way that is unlikely to make them feel shame. And they still feel shame, right? So I can do everything right, but I can't control how you feel about yourself in response to that. That would be considered accidental shaming. That also is happening a lot around us. And in that regard, we need to not only recognize when that might have happened and repair that, but also help people be able to receive that treatment and maybe not feel shame. And that becomes shame competence at an individual level. With the first two types of shaming, we got to get rid of it. There's no place in healthcare for these types of shaming treatment. None. Full stop. And if we have come to accept that this is okay, we need to be finding another profession. Our patients deserve better, and our team members deserve better. Mindless shaming, we need to minimize that, right? We're not going to be perfect at this. We're going to sometimes mindlessly shame someone. We just need to be as aware as we can about the possibility of doing this. And then accidental shaming and mindless shaming, we just need to repair it once it's happened. So this is where shame competence requires us to consider, even in this perfect situation, you still might be feeling shame. Let me make sure that's not the case. And if I'm seeing signs of it, let me come to you and provide support so that it doesn't linger and manifest. Okay, and so ways to do that is, don't intentionally shame people. There's better ways to motivate meaningful behavior change that is not so emotionally distressing. Be nice. I have a 3 and a 4-year-old, and so much of what we work with them on, I could just put in this lecture, is just being kind and being thoughtful and thinking about how other people feel as a result of your treatment. Thinking about the words you use, right? So instead of saying you're so unprofessional, this thing you're doing is unprofessional and you got to stop. Instead of saying you're never going to make it as a surgeon, right? Or a CRNA, you need to work on your intubation skills or your dexterity. React to the person and not the behavior. Remember that this is a person who's probably going through something, right? The behaviors are often manifestations of more internal distress. And so try to really remember that you're reacting to a person and not the behaviors. But at the same time, focus the response on the behaviors and not the person. Does that make sense? So this is a nuanced, but I think it's a little bit higher level of shame competence. If someone's really being a jerk, before you just want to knock them down a few levels and throw them through a brutal remediation process, can you first consider what might be driving this and what type of support might they need? And then once I am ready to sort of provide that support, now I'm really focusing on the behaviors themselves and not trying to necessarily shame or change the person. And I think this is really challenging. And then this question I think is really helpful. Is my response likely to help them grow and improve? Yes or no? And if the answer is no, you need to revise your response, right? Or you need to wait a day, or you need to go eat something and not be hangry. Whatever is driving the possibility that treatment is not going to cause them to grow and improve needs to be addressed. Supporting, this is really, I'm going to just briefly attend to this. This is the ability to proactively help someone constructively engage with their shame. There are ways to do this. A lot of them bridge to other ways that we support people. We can take a lot from allyship, whether someone's being the recipient of micro or macroaggressions. Being an ally to someone who's being shamed is very similar to that. And there's likely a lot of overlap. Normalizing the emotions, naming it for them. Say, I think you might be feeling a shame reaction. That's a normal emotion. It's challenging. We all are stuck with it, but here's what you can do to engage with it healthfully. Sharing your own experience is very, very powerful, especially if you're in a position of power. Unskewing their frame of reference, so helping them see that it isn't just you and all your failures and shortcomings here. That's not what's at play here. It's just these things you need to do to get better. So orienting them more towards action that can be changed and fixed, and then facilitating support resources. So you don't need to be a psychotherapist here. Getting people to higher levels of care and therapy can be very helpful, if not just getting them to a healthcare professional that can support them through this. And then committing to that journey of growth and recovery that comes after it. The final thing, and this is really just a plug for the transformative power of this. I mean, this is the high level shame competence that we hope to build within an institution or a group, and it really comes at the sort of top down level as opposed to just the bottom up. We got to have shame confident leaders. They have a lot of influence about how organizations run. They need to be shame confident. You can't just make all the sort of the soldiers shame confident. The leaders got to be too. We need to be able to examine and modify those practices, policies, material conditions that have embedded shame. We're starting to think about how to do some consulting help to identify some of these practices and policies and to help modify them in ways that minimize that risk of shame, which is often just unseen. We need to be able to, if we're going to adopt these shame competent approaches to our work, we need to be able to really create organizations where it's diffusely shared and learned and adopted. And then we need to be able to disseminate the best practices that we learn as we do that, the lessons we learn, and then the outcomes of doing that. And we're in the process of developing what some of those outcomes may be, that we're attaching to the training programs that we're building. Okay, speaking of those training programs, Luna right now is doing some really cool work with shame competence in sectors outside of healthcare. Policing, believe it or not, in the UK are getting trained in her region to be shame competent. Police officers can use a lot of that here. Social work and in trauma-informed practice, and then we're developing it for both healthcare and health profession education, both here and in the UK, and the goal is to really make this an international effort. So with that, I know we're almost out of time. They told me don't rush, even if it means we don't have as much time. I would certainly welcome emails with any follow-up questions. We're going to be building and rolling out the training over the next 6 to 12 months. So if you have any interest in engaging with us further, James at the email at the bottom is kind of receiving those inquiries, and then we'll be back in touch with you. All right, Jen, back over to you.
Thank you so much, Will. I think I echo everyone in the chat saying, an excellent presentation. And yes, I agree. It was great to get through we didn't want you to rush because you had such good content. And so for those that do have questions, burning questions, your email is there, although we'll try and work with you and see about follow-up because there's been a few similar themes in some of the questions that have been asked. Well, if you don't mind just flipping to the next slide for me.
Oh, yeah, sure.
For some closeout stuff. So before I officially close us out, once we end this webinar, you're going to see an evaluation form that appears in your browser automatically. So we would really value your feedback and appreciate you taking a couple minutes to fill that out. And then as a reminder, if you're looking for that CE credit, the information is right here on the screen. So since I know we are at the end of the hour, Will, I want to thank you so much for your work. And if you want to go back to your other slide that has your information on it, just so everyone can see that again, to visit your website at the Shame Space the Shame Lab, or contact you. Otherwise, we'll follow up with everyone with a recording of this webinar. But again, thank you, Will, for taking the time. We really appreciate your vulnerability, your expertise in this, and bringing forth a really important topic that is quite prevalent in our setting. But thank you all for joining us today, and I hope you have a great rest of your day.
Thanks all. Have a great day.